Hello, welcome to this presentation entitled Atherosclerosis Can Be Reversed. In this presentation, we will look at several studies that have been done that demonstrated an actual reversal of atherosclerosis. First of all, let's quickly review what atherosclerosis is. Atherosclerosis is the buildup of plaque in the arteries. The plaque itself is made up of fat, cholesterol, calcium, and other substances found in the blood. Calcium accounts for about 20% of plaque. So by knowing how much calcium is in your coronary arteries, you will know how much coronary plaque you have. We do have a test that does measure your coronary calcium. It is a cardiac CT scan for coronary calcium. It's a non-invasive way of obtaining information about the presence, location, and extent of calcified plaque in the coronary arteries. This test provides you with a coronary calcium score, often abbreviated CCS. In atherosclerosis progression, it has been historically found that your calcium score increases at a rate of about 33% per year if left untreated. That's quite a bit. Another way of putting it is that it would take about 2.5 years for your calcium score to double. So if you had a calcium score of 100, your first year would be 133, and then take 33% of that, etc. So 33%, a rate of 33% per year is the rate at which calcium accumulates in your arteries if left untreated. So that is why it is important to do preventive maintenance on atherosclerosis. Now, before we go looking at the studies that actually caused regression of atherosclerosis, we'll first look at a study that shows the prevalence of atherosclerosis. As with all these studies, there's the abstract shown here, and there's the title, and you can always take the title and Google it, and you can look at it more deeply if you want to. I will always provide a summary of the study and the results in subsequent slides after the study. So you can read it at your leisure, but for the purpose of moving on, this study was of 262 people who had died who had donated their heart for heart transplantation. And they analyzed these 262 people, dead people, and looked for atherosclerosis in their coronary arteries. They defined atherosclerosis as shown in the underlined section there with a site that had an intimal thickness of 0.5 millimeters or more of plaque. And in red, you can see what the conclusion was. This study demonstrates that coronary atherosclerosis begins at a young stage and that lesions are present in 1 of 6 teenagers. These findings suggest the need for intense efforts at coronary disease prevention in young adults. Now we'll look at this a bit closer in the next slide. Now from the previous study, they plotted the percentage of people they found who had atherosclerosis as defined by that 0.5 millimeter threshold. That's the y-axis. That's the percentage of people who had atherosclerosis. And the x-axis here is the age of the people. So for instance, people less than 20 years of age, they found 17% already had atherosclerosis. Between 20 and 29, 37%, etc. Till you get up to greater than 50 years old, they found 85% of them had atherosclerosis. So if you have a son or daughter, the next time they say to you, I will wait until I get old before doing something about cardiovascular disease, you can tell them, for a teenager, there is already a 17% chance you have atherosclerosis. And if you're 50, of course, you have an 85%. So, I mean, it's pretty certain. And they don't have anything after 60, but that would be even higher. So the message here is start prevention early. Okay, this first study is a study that involves reversing atherosclerosis using statin drugs. Statin drugs are the drugs that lower your cholesterol. And this was a study that lasted a long time. It was a 10-year study. It involved 113 westernized Hong Kong Chinese people. And we'll look at the results in the next slide. This study is the calcium scores at the beginning of the 10-year study. So it's mainly for information purposes. You can look it up, look at the scores, and get an appreciation of what the scores were at the beginning of the study. Of course, you'll see the normal pattern that as you get older, the calcium score goes higher. For one reason or another, I don't understand why, but in the men's section, the 50 to 59 had a lower score than the 40 to 49. But anyways, that's what they found. If you look at the women's section, starting at about 60, they really start going up in a hurry. So we'll look at what they found once they treated these people with statin drugs over a 10-year period. Okay, this slide shows you a summary of the first study. It was a 10-year-long study of 113 westernized Hong Kong Chinese people, 64 men between 28 and 83 years old, 49 women between 36 and 86 years old. All patients were ensured to maintain the following protocol. They lowered their LDL to less than 2.63 millimoles per liter with statin drugs, and if necessary, that was probably necessary for most of them. They controlled their blood pressure so that it was lower than the 120 to 130 range, and 80 and 70 on the diastolic side. And they lowered their fasting blood glucose to less than 6.1 millimoles per liter. So for the 10 years, these three parameters were maintained. Patients were also counseled about risk factor modifications that included a strict diet, smoking cessation, and stress reduction if applicable, regular exercise, and weight control. And they looked at the outcome that was measured was the coronary calcium score after 10 years. Okay, and here are the results of that 10-year study. For the entire population, the mean CCS, mean coronary calcium score, increased at a rate of 24% per year. For the group that followed the strict risk factor modifications, that included the diet, stop smoking, exercise, etc., plus the statin drugs to get their LDL lower than the 2.63, the mean coronary calcium score increase was 16.4% per year. Now this is in contrast with the historical data that untreated patients experience a mean CCS increase of 33% per year. So what this study showed as an overall effect was that they were able to half the rate of increase from basically 33% if left untreated to 16.4%. Furthermore, though, a 20.4% subset of the group actually had a decreased calcium score after 10 years. So 1 in 5 people after 10 years experienced a decrease in coronary calcium score, which is basically a reversal of atherosclerosis. So this demonstrates that it can be done. It was done with drugs and lifestyle modifications. The second part, it shows you the breakdown of how the distribution was. Like group 1, 20 patients had a calcium score at 0 at the beginning and also at completion. 52 patients had an increased calcium score on statins alone. 18 patients had an increased calcium score on statins plus risk factor modifications. Another 18 patients had a decreased calcium score on statins alone. And 5 patients had a decreased calcium score on statins plus risk factor modifications. This next slide is a study done by Dr. William Davis and others. I've mentioned Dr. William Davis in several sections of this document. This study looked at possibly reversing atherosclerosis using a combination of supplements, namely a reduced carbohydrate diet with emphasis on elimination or reduction of grains, especially wheat, elimination of sugars, and elimination of starches, such as potatoes, corn. The other supplements used were the omega-3 DHA EPA fish oil, vitamin D3, niacin, and a statin drug if necessary. This next slide is a summary of the study. First of all, the supplements and possibly statin drugs that were used were to achieve an LDL less than 1.55 millimoles per liter, to achieve the HDL of greater than 1.5 millimoles per liter, and achieve triglycerides less than 0.68 millimoles per liter. This was achieved by a reduced carbohydrate diet with reduction of grains, sugar, and starches, omega-3 fatty acids, niacin, which is vitamin B3 and or a statin drug, and vitamin D3. The amount of vitamin D3 was the amount necessary to get the vitamin D25 OHD test to be greater than 125 nanomoles per liter. So this was the setup. All the patients had these characteristics, that through these supplements they were able to achieve the specific LDL, specific HDL, specific triglycerides, and the specific vitamin D levels. And this was done over an 18-month period. And the chart shows the results. Group 1, which represents 44% of the patients, had an average of a minus 14.5% reduction. In other words, they 14.5% reduction in their calcium score. That is reversal of atherosclerosis. Group 2, which consisted of 49% of the patients, their calcium score increased at a rate of 12%, and Group 3, which consisted of 7%, had a calcium score increase of 44%. So let's look at this and realize that 44% of the people actually regressed their calcium score. That is very significant. And minus 14% is a good amount of reduction. The group 49% had the calcium score increased by 12%. Now you have to appreciate that untreated, they would have the calcium score would have increased at a rate of 33% per year. So to go from 33% down to 12%, it's like a 1/3 of the rate. So you've slowed it down by 1/3. And unfortunately, about 7% of the group really did not achieve anything from this study. This next study involved to see what pomegranate juice consumption for 3 years, what effect that would have on the carotid artery. And here's a summary of that study. 19 patients with severe carotid artery stenosis, defined as 70 to 90% stenosis, which is significant, were involved in the study. 10 were given pomegranate juice and 9 were not. The amount of pomegranate concentrate used was 50 milliliters per day, containing 1.5 millimoles of total polyphenols. This is equivalent to 8.3 ounces, 250 milliliters of 100% pomegranate juice. And the chart below shows the results after 1 year. The control group, the placebo group, naturally their carotid arteries continue to increase in plaque by 9%, the thickness of it. On the other hand, the pomegranate juice group saw a reduction of 35% in the thickness of the carotid artery. Now that is an amazing result. Now, one thing you should keep in mind is to drink 250 milliliters of pomegranate juice every day would involve a lot of sugar intake, and that may not be the right way to go. Probably a better way is to actually eat the pomegranate fruit or to use a pomegranate extract. But you can see what amazing results pomegranate has on the atherosclerosis. It reduced atherosclerosis. This next study looked at the effect of high-dose garlic powder on atherosclerosis plaque. The test study was conducted over a 48-month period. That's 4 years. And we'll look at the results in the next slide. So a summary of the study is as follows. A 900 milligrams standardized garlic powder was used per day. It was a 4-year double-blind study. It involved people 50 to 80 years old, and the benefits were most notable in women. Now, it's not quite clear how to read the results from the study there, but what it showed is that the garlic reduced the progression relative to people who did not use garlic. It wasn't so much that it regressed it, but it slowed it down by the 5 to 18%. So we can say that garlic plays an adjunct role in slowing down atherosclerosis. This next study looked at homocysteine and atherosclerosis, and homocysteine is controlled mainly by the 3 B vitamins, folic acid, which is vitamin B9, pyridoxine, which is vitamin B6, and cyanocobalamin, which is vitamin B12. And they investigated 2,500 milligrams of folic acid, 25 milligrams of pyridoxine, and 250 micrograms of cyanocobalamin, and what effect that would have on progression of the carotid artery. A summary of this study is that patients were given the 3 B vitamins that are known to decrease homocysteine, namely folic acid, 2,500 micrograms per day, pyridoxine, 25 milligrams per day, and cyanocobalamin, 250 micrograms per day. That's vitamins B9, B6, and B12. Patients were classified into 2 categories based upon their initial homocysteine levels. 14 was a threshold, those above 14 micromoles per liter, and those below 14. And the outcome measured was the carotid plaque. Here are the results of the study. The y-axis is the rate of progression of plaque measured in square centimeters per year, and the x-axis is the different groups. As you can see from the blue bars, these are the ones who, this was the rate of progression of plaque prior to vitamin B therapy. The higher the homocysteine level, the faster the progression of plaque. So homocysteine is a contributing factor to plaque buildup. But now if you look at the red bars, which is after vitamin B therapy, the group that had less than 14 in homocysteine, they experienced a very small but nonetheless a reduction in the progression of their plaque. So it actually, they experienced reversal. And the group that had homocysteine levels greater than 14 experienced negative 0.05 centimeters squared per year. So it is actually quite amazing that these 3 B vitamins solely by themselves were able not only halt the progression of carotid plaque, but actually reverse it slightly. This study is a study on the effect niacin would have on atherosclerosis. They used a 2,000 milligram dose of niacin in combination with patients who are already using a statin drug. And we'll look at the results of this in the next slide. Summary of this niacin study is as follows. It involved 71 patients with low HDL, that being less than 1.0 millimoles per liter, and they had either type 2 diabetes with coronary heart disease or carotid peripheral atherosclerosis. 2,000 milligrams of niacin was given, niacin being vitamin B3, or a placebo was added to the patient's already statin therapy. The primary endpoint was the change in the carotid artery wall area quantified by magnetic resonance imaging after 1 year. So they looked at basically the change in the wall area of the plaque, the amount of plaque basically in the carotid artery after 1 year. And the results are shown in the graph. The placebo group, of course, their plaque area continued to increase, and it increased at the rate of 1.2 millimeters square in that 1 year. However, the group that took the 2,000 milligrams of niacin saw a reduction of the plaque area, and the reduction was minus 1.1 millimeters square. So once again, we have a result here of reversing atherosclerosis, and this is done using niacin, which is just simple vitamin B3. Now, niacin is a perfect cardiovascular supplement. It does everything you want it to do. It raises HDL significantly. It lowers triglycerides significantly. It lowers LDL modestly, but it reduces the worst kind of LDL, namely the small LDL. The small LDL is the most atherogenic form of LDL, and niacin reduces the amount of small LDL. And this study just showed that it also regresses atherosclerosis plaque. This next study looked at the endogenous antioxidant superoxide dismutase, which is always abbreviated SOD or just simply SOD, and that's the way I'll refer to it from now on, SOD. SOD is an endogenous antioxidant enzyme that exists in our body. It's made within our body. However, people have developed a technology now where they can take the SOD molecule and make it absorbable by wrapping it in with a wheat protein. The wheat protein is gliadin, and the name of the product is glycodin. So what they did is they gave patients 500 milligrams of glycodin and investigated what effect it would have on atherosclerosis. And that's what we'll look at in the next slide. So a summary of the SOD study it involved 76 patients without clinical signs, symptoms of cardiovascular disease, but who were considered to be at risk because of family history of stroke, a height-to-weight ratio of greater than 20 to 30% above the normal range considering the BMI. They also had to have high blood pressure defined by greater than 160/90. Their total cholesterol was greater than 2.5 grams per liter. Triglycerides were greater than 1.28 grams per liter, and LDL cholesterol was greater than 1.4 grams per liter. And they also had intima media thickness of greater than 0.7 millimeters. So all 76 patients had this as the criteria upon entering the study. And they were divided in two groups. One group was the control group, the placebo group. They received no glycodin, which is no SOD, no superoxide dismutase. And the glycodin group received 500 milligrams daily. So that's 500 milligrams of SOD. The results are shown below. The y-axis is the change in the intima media thickness, and the x-axis is time versus for the two groups. So the blue bars are the placebo group, And you can see that after 12 months, the intima media thickness increased by 0.01 millimeters, and then by 0.013 after 18 months, and after 24 months, 0.017. So naturally what you would expect is that the plaque just gets bigger. Now, the people who were given 500 milligrams of glycodin, after 12 months, they experienced a very, very small reduction in the change of the intima media thickness, IMT. After 18 months, though, it continued to decrease. It decreased to minus 0.005. And then within 24 months, it doubled, the decrease doubled, to 0.011. So this is actually very impressive, because the glycodin stopped the progression of plaque after 12 months, and then further decreased the amount of plaque as time went on. And we only have results after 24 months, but it could very well be that the plaque would have gone even further down after 36 months and 48 months. So 500 milligrams of our endogenous superoxide dismutase antioxidant will reverse atherosclerosis. This study is a study involving the effect of vitamin K on atherosclerosis. It is done on animals. It was done on rats. It was a 12-week study. The first 6 weeks of the study, the purpose of which was to calcify the rats, and the second 6 weeks of the study was to see how vitamin K and in what amounts it would require to reduce or eliminate atherosclerosis. So a summary of the study is that arterial calcification was induced in the rats by treating them with the drug warfarin for 6 weeks, designated weeks 0 through 6. Once the rats were severely calcified, the warfarin treatment was stopped. They were then fed either a normal vitamin K1 diet or a high vitamin K2 diet for 6 weeks, weeks 7 through 12. Both the aorta and carotid arteries were measured for calcification. And here are the results of this study. Both for the aorta calcification and the carotid calcification. The graphs are similar, so we can just focus on one for the moment. If we look at the aorta calcification, the y-axis represents the percentage change in arterial calcium, and the x-axis is the 3 different groups. The control group. The control group are the rats that nothing was done to them. They were never calcified, and they always received a normal K diet. The normal K1 group, these were calcified for the first 6 weeks using the drug warfarin, and then the drug was stopped, and they were fed a normal K1 diet. And as you can see, by the end of the 12th week, their calcification had actually increased 43% from the week number 6. So a normal K1 diet had really no effect whatsoever on being able to reduce the calcification. It increased by 43%, which is a huge amount. On the other hand, the high vitamin K2 group were calcified for the first 6 weeks using the drug warfarin, and then the calcification process was stopped. and they were fed a high vitamin K2 diet. And during those 6 weeks, the last 6 weeks, the arterial calcification percentage change was a drop of actually 31%. And that is huge. And at the carotid artery, you'll see a similar pattern. So what do we see from here? We see that the calcified rats who consumed a normal K1 diet continue to have progression of calcification of both the aorta and carotid arteries. In other words, a normal K1 diet was not able to regress arterial calcification. The calcified rats who consumed a high vitamin K2 diet were able to have regression of both the aorta by 31% and the carotid arteries by 28%. In other words, a high K2 diet was able to regress arterial calcification. This study is a remarkable study, and it shows the power of vitamin K, and in particular vitamin K2. Okay, now this slide is a slide showing the matrix GLAP protein, abbreviated MGP. MGP is a vitamin K dependent protein. It exists in the arteries, and its job is to remove calcium from the arteries. However, MGP needs to become activated, and it can only become activated by vitamin K. If there's not sufficient vitamin K, a significant portion of the MGP will remain inactive and basically useless. So if we look at this graph, we will get some very interesting observations. First of all, the three groups are there: the control rats, the normal K, and the high K2. The black bars are the total MGP in the arteries. This is when they dissected the rats and they measured the MGP in the arteries. The gray is the active MGP, which only becomes active with vitamin K. And the white is inactive MGP, which means it did not have vitamin K to become active, so it basically was useless. So if we look at the control rats, you will see that since they were never calcified, they were fed a normal K diet, virtually 100% of their MGP that they produce is active. So there's enough vitamin K in their diet. Since they don't have any calcification, all of it is active. And you can notice the level, just for reference purposes, it's around at the number 5, just to use as a reference. Now let's move over to the normal K1 diet. Once again, just to repeat, these are the rats that were for the first 6 weeks were calcified using warfarin, and then the warfarin treatment was stopped, and they were fed a normal amount of vitamin K1. Now, you can notice there's a shift in pattern in the distribution between the total active and inactive. You'll first notice that the total amount of MGP is actually more than in the control rats. It's at about the number 6. So the body of the rats actually are able to sense the calcification, and in an attempt to clear the calcification, the body produces more MGP. However, more MGP the body produces, it drains the vitamin K because it needs vitamin K to become active. So what happens though, for a normal K1 diet, there is not enough vitamin K to satisfy the needs of the MGP. So you'll see that In the normal K group, the gray area, which is the active, is significantly a very small percentage relative to the total. And in fact, most of it, the white portion, is inactive. So there's not enough vitamin K in a normal K1 diet to satisfy the needs of activating all the MGP protein in the arteries. And now let's go to the high vitamin K2 group. Once again, you see this phenomenon where the total MGP produced by the body is much higher than the control rats. Once again, this has been explained by Dr. Leon Sugars and his associates that the body has a feedback mechanism where it can sense local calcification and in that area produce more MGP in an attempt to clear that calcification. So the body produced a lot of MGP in the high K2 group. You can see it's around almost 11. The amount of active MGP was much higher than the other groups. And these are the active MGP is the molecule that actually removes calcium. Now, while it was not 100% activated, because you can see from the white area we had some inactive, you can see that the gray area, which is the active MGP, is much larger than the other two groups. So in other words, that gray area, the active MGP, is what's doing the, the clearing of the arteries of calcification. And that's why this group, because it had so much active MGP present, was able to reduce the calcification by the percentages we showed in the last graph, which was about 31%. But the normal vitamin K1 group, you can see that their active MGP is actually less than the control rats. But they need more active MGP because they're calcified, but they don't have enough. So their calcification actually continued to progress. This is a very, very important point I want to get across here. Your body, when there's calcification in the arteries, tries to clear the problem by producing more MGP. However, you have to have enough vitamin K in your body to activate that increased amount of MGP. Otherwise, it's totally useless. Okay, very important. The higher the calcification in your body, the more MGP your body produces, the more vitamin K you need. So just reading the different points here and summarizing here. In the control group, a relatively low vitamin K intake is sufficient for complete activation of MGP and for preventing arterial calcification. So that's just the normal control group. The second point, warfarin initiated calcium accumulation in the arteries of MGP. Warfarin initiated calcium accumulation in the arteries, increased the accumulation of MGP in these areas. That's the point I just mentioned. This can be explained, as this explanation is from Dr. Leon Sugars and his group, by assuming a feedback mechanism by which a local calcium stimulates MGP expression in an attempt to prevent calcification. An unexpected finding was that the calcium accumulation also continued in the normal vitamin K group, even after warfarin treatment had been stopped. We speculate that the calcium salt precipitates induce a high MGP expression level, causing a high local vitamin K requirement, which is not met by the normal vitamin K diet. So, hammer this point once again. If you got calcification in the arteries, your body produces more MGP in an attempt to clear it, but if it produces more MGP, it needs more vitamin K. Otherwise, that MGP that gets created never becomes active and therefore is not able to clear the arteries. And from this graph, you have to bear down and look at the gray areas here, and you can see the high vitamin K2 group had active MGP at around the 8 level, whereas the normal vitamin K group had an active MGP at around the 3 level. That's why the high vitamin K2 group was able to regress calcification, whereas the normal vitamin K group, the calcification increased, and it increased by, as you saw in the last slide, by 43%. This is a very important slide. If you understand this slide, you really understand the appreciation of the importance of vitamin K2. In this slide, we're basically going to summarize vitamin K2 because it's so important that it's good to have a little summary here. Vitamin K2 is a true superstar in the pursuit of reversing atherosclerosis. Matrix glycoprotein, abbreviated MGP, is a vitamin K dependent protein that exists in the arteries. Its job is to move calcium out of the arteries, but only if it is activated. It is activated by vitamin K. The next point is one of the most important points, you take home message. MGP is the most potent inhibitor of arterial calcification currently known. So that says it all. If you want to get calcium out of your arteries, there is nothing that gets calcium out of the arteries better than MGP. And MGP needs vitamin K. This became apparent in an association study. It's quite famous. It's just simply referred to now as the Rotterdam study. It showed that a high dietary intake of vitamin K2, but not vitamin K1, has a strong protective effect on cardiovascular health. This population-based study, which took place over a 10-year period, followed 4,807 initially healthy men and women greater than 55 years of age from the start. Findings from the study indicate that eating foods rich in natural vitamin K2, at least 32 micrograms per day, resulted in a 50% reduction of arterial calcification, 50% reduction of cardiovascular death, and 25% reduction of all-cause mortality. Now, let me make this perfectly clear. The reduction there is relative to the people who had the least vitamin K2 in their diet. In other words, the 50% reduction is a relative reduction, relative to the lowest vitamin K2 group. The high K2 had a 50% less calcium than the people who consumed the least amount. It does not say that it regressed calcification by 50%. Make that clear, okay? So what this gave scientists the impetus to follow through on, since vitamin K2 seems to have an effect on reducing calcification, let's progress it further and get into intervention study. And that's what the rat study that was mentioned before actually showed, that when you intervene with vitamin K2 in a high amount, you will actually get an absolute reduction of arterial calcification. And that's in the last point. In the intervention study, calcified rats who consumed a high K2 diet were able to have regression of both the aorta by 31% and the carotid by 28%. In other words, a high K2 diet was able to regress arterial calcification. So now leads to the question is, what dose of vitamin K2 is required in humans to reverse arterial calcification? And the answer is that there are current human clinical trials that are in progress to try and answer this question. We saw from the rat study that we know how much it was required for rats, but how much is required in humans? However, the best that you can do is to take enough vitamin K2 to activate all the MGP in your arteries. Once you've activated 100% of MGP in your arteries, then you can't do any better than that. So the next question, logically, is what dose of vitamin K2 is required in humans to activate all the MGP? And this has been answered, at least for a certain group of people, by Dr. Leon Sugars and his group. Dr. Leon Sugars has demonstrated that a 360 microgram dose of MK7, which is vitamin K2, for 3 months will almost completely activate all MGP in healthy volunteers. And I stress the word in healthy volunteers. So when he initially measured the amount of inactive MGP in these volunteers, and he found that on average they had 35% inactive MGP. When they were given 360 microgram dose for 3 months of vitamin K2, virtually all the MGP became active in these healthy volunteers. Now, in people with severe arterial calcification, a dose of greater than 360 micrograms may be required because MGP production will be upregulated in the areas where arterial calcification exists. Remember, going back to that chart of MGP, the important point was that your body produces more MGP the more calcification it has, and therefore requires more vitamin K. So the requirement for a 20-year-old who has basically very little calcification is not the same requirement for a person who's 70 or 80-year-old who has lots of calcification. So we know that 360 micrograms activates all the MGP in healthy volunteers, but what dose is required for an unhealthy person of around 70, 60, or 80 years old? It's not really known, but it's going to have to be greater than 360 micrograms, potentially. Now, the thing to remember about vitamin K, there is no toxicity with vitamin K. Hence, you can take as high a dose as dictated by your financial situation. You cannot overdose on vitamin K. There are certain vitamins and minerals that if you take too much, they become toxic. Vitamin K has no toxicity level. So that basically, if you can afford to take 1,000 micrograms, you can take 1,000 micrograms. Okay. Now, it's interesting to see what are the experts taking, the people who are really in the know about vitamin K. And one of these experts is from the Netherlands, who works with Dr. Leon Sugars that I mentioned before. He is Dr. Cees Vermeer. I'm not sure if I pronounced that right. He's a world-renowned vitamin K expert. And in an interview with Dr. Joseph Mercola, he personally, meaning Dr. Vermeer, takes 360 micrograms of MK7. I don't know how old Dr. Vermeer is, but I looked at the picture and I would say he's probably somewhere in his 50s, maybe even 60s. and he personally is taking 360 micrograms. So that should give you an idea of maybe what kind of dose you should be taking. And of course, that dose is the foundational, was that it activates all the MGP in healthy volunteers. That's what was proven by Dr. Leon Sugars. Now, if you want to compare vitamin K2 foods, they're kind of funny foods. They're not your standard type of foods that you would think of. Vitamin K2 is in fermented products, and the highest amount of vitamin K2 is in a Japanese food called natto, which is basically a fermented soybean food. And it turns out a 40-gram serving of the Japanese food natto contains 360 micrograms of MK7. And the Japanese have this quite often for breakfast. So basically, the Japanese are the ones who have the highest amount of vitamin K2 in their bodies because they're consuming this food called natto. Nothing compares to natto in terms of the amount of vitamin K2. The next lowest foods would be things like fermented cheeses and liver and stuff like that. But those numbers are way, way down from 360. But natto is a food that not very many people would like, apparently. So the best thing probably to do is to simply take a supplement. This study looked at the effects of green tea and black tea and its ability to inhibit atherosclerosis on hamsters. So a summary of the study was that the green tea was given in human equivalent doses to hamsters. Atherosclerosis was inhibited 26 to 46% in those receiving the lower dose, which was equivalent in humans to 3 to 4 cups per day, and 48 to 63% in those receiving the higher dose, which is equivalent to 10 cups a day in humans. It is not clear from the abstract how to interpret the results. I do not think the green tea reversed atherosclerosis. Rather, it seems that compared with the untreated hamsters with induced atherosclerosis, the green tea hamsters with induced atherosclerosis had significantly less plaque. Suffice it to say that green tea plays an adjunct role in slowing down the progression of atherosclerosis. This study looked at the effect of vitamin E, specifically a combination of tocotrienols and alpha-tocopherol in being able to reduce carotid stenosis. And the abstract's there, you can read it, and we'll get down to the results. So there were two groups of patients followed for 18 months. One group received this product called Palm Vitae, which is a tocotrienol product, but it was enriched even further with gamma tocotrienol and alpha tocopherol. So it's basically a broad spectrum vitamin E, very much though heavily favored in the tocotrienols. The other group was the placebo. And the measured outcome was the carotid stenosis after 18 months. And the chart below shows what happened. The blue is the Palm Vitae group, the tocotrienol group, and the red is the placebo. And they're basically categorized in three sections. People who experienced regression, that means reversing atherosclerosis. Neutral, where there was the plaque neither went up or down, just stayed where it was. Or progression of atherosclerosis of the carotid artery. Now you can see here from the Palm Vitae group that 28% of the patients actually experienced a regression, while 0%, none of the placebo received got any regression. With respect to neutral, 64% of the palm vitae were neutral, 60% of the placebo. And with respect to progression, 8% of the palm vitae as opposed to 40% with the placebo. So you can see that the vitamin E complex is very favorable towards preventing and, in certain cases, in this case 28%, reversing atherosclerosis. Tocotrienols are a very, very powerful antioxidant family of the vitamin E. Okay, we've reached the end of these studies now, and just going to have a summary of the conclusion. It appears that reversal of atherosclerosis requires a multifaceted approach to be successful. In these studies, we found that to reverse atherosclerosis, the following supplements were useful. First of all, a multivitamin and mineral is a no-brainer. You need that to fill in the gaps of your diet. You have to get your vitamin D3 level to a blood level of at least 125 nanomoles per liter, but preferably even higher, closer to the 125 to 200 nanomoles per liter. Vitamin K2 is a must. You must take probably somewhere around 360 micrograms or more. The older you are, I think the more you should take. The omega-3 fatty acids, once again, are a no-brainer. You have to take at least 1,800 milligrams of DHA plus EPA, and once again, preferably higher. Another thing you have to do is reduce carbohydrate diet with emphasis on reduction, elimination of grains, sugar, and starches. That is a must to control your LDL and HDL and your triglycerides, and very importantly also to reduce the small LDL. Regular exercise contributes to reducing atherosclerosis. We saw that a vitamin B complex, especially folic acid, 2,500 micrograms. Now, 2,500 micrograms, just you have to be aware that if you have a vitamin B12 deficiency, you should not be taking that much folic acid. So you have to be careful with that. And you may not have to take that much folic acid if you're taking all these other things, because there'll probably be a synergy in all these things working together. Pyridoxine, 25 milligrams. Cyanocobalamin, 250 micrograms. Niacin, which is an absolutely great cardiovascular nutrient, 500 to 2,000 milligrams. And these are all the B vitamins, B9, B6, B12, B3. Pomegranate juice is wonderful in reducing atherosclerosis. You could take 250 milliliters of juice every day, but that's got a lot of sugar. Preferably, you could eat the 1.25 of fruits, meaning 1 1/4 fruit or just one fruit a day. Or you can just go to a supplement and get like 125 milligrams of the pomegranate extract. Superoxide dismutase, the sod supplement, 500 milligrams of glycodin. Vitamin E complex. This is very important to get it right. Vitamin E has two groups, the tocopherol group and the tocotrienol group. Most vitamin E supplements just give you alpha tocopherol. That's a mistake. you have to take a supplement that has alpha tocopherol as well as a sizable amount of gamma tocopherol and a little bit of the beta and the delta tocopherol. Then you have to add on the tocotrienols. That combination is a vitamin E complex, and that's what is necessary to achieve or prevent atherosclerosis. Statin drug if necessary, and I don't think it'll be necessary if you follow all these other things. You should get your blood pressure in the normal range of less than 120/80. You should get your blood glucose and get into the optimal range, which is less than 4.7 millimoles per liter. Where do I get this number? I get it from if you go back to my blood tests and you click on the optimal icon or whatever, optimal link actually, it'll direct you to what where these levels come from. And they have noticed that when your blood glucose is less than 4.7, your cardiovascular risk is greatly reduced. You should try to achieve an optimum cholesterol profile, which would mean an LDL less than 1.8 millimoles per liter, a HDL greater than 1.5 millimoles per liter, and triglycerides less than 1.1 millimoles per liter. Once again, these numbers come from going to my blood tests and clicking on the link optimal, and you'll have the references for those. Now, a special note on the optimal value of LDL being less than 1.8 millimoles per liter. This value is from a monograph which indicates that if you were to get your LDL that low, it would take out the risk factor of Lp(a). However, a better way to find out if you have a risk factor of Lp(a) is to measure it, rather than trying to knock down your LDL to such a low level. So, while I wrote it as an optimal value, in fact, I do not recommend you get your LDL that low, especially if you need to take a statin for it. That would rule it out. So I would kind of disregard that as a optimal value of LDL. So if you were to combine all these supplements, your chances of reversing atherosclerosis would be as good as they can possibly get. And I encourage you to incorporate as many of these as possible, but make sure you get at least the vitamin, the multivitamin, the vitamin D3, the vitamin K2, the omega-3 fish oil, reduce your carbohydrates, get the regular exercise, get the vitamin B complex, get your blood pressure in the normal range. Now, in addition to the supplements mentioned on the prior page, there's adjunct supplements, meaning additional supplements that are excellent for the cardiovascular system. And these are listed in section 2.3, the cardiovascular superstars. There's green tea, garlic, vitamin C, thiamine, vitamin B1, coenzyme Q10, L-carnitine, R-lipoic acid, L-carnosine, choline, extra virgin olive oil, human earthing, the endogenous antioxidant glutathione, trimethylglycine, potassium if necessary to balance your dietary potassium to sodium ratio to get it at least greater than 4. Broccoli sprouts extracts, which has sulforaphane, chromium vanadium, which is excellent for blood sugar, resveratrol and OPCs, all these purple polyphenols that have excellent properties in cardiovascular, and also cocoa polyphenols, as well as pycnogenol, which is another great source of OPCs. So if you want to add these in addition to what's on the other slide, you would be doing yourself a great favor also. And we could very well find out one of these days that someone will do a study and find out that one of these particular ones by itself was able to indeed reverse atherosclerosis. But I don't see any studies where anyone actually did a study on one of these particular, but we know from studies that each one of these has a beneficial effect on cardiovascular, be it the endothelial lining of your cells, homocysteine reduction, lowering fibrinogen or platelet aggregation, and all these things, lowering your blood sugar. All these things and they're all powerful antioxidants, which is basically the root cause of atherosclerosis. So once again, I encourage you to incorporate all or as many of these as possible. Thank you.